and then I will present you in English. I will introduce to the audience in English.
Okay.
Ya ready. Estamos listos.
Muy buenas tardes a toda la audiencia. Continuando con el programa del día de hoy, miércoles 24 de febrero, les doy la más cordial bienvenida en nombre de Jorge Herrera Ramos, señor embajador de la UNESCO y chairman del World Congress of Neurosurgery UNESCO, ASPNet, Walter Irandi y Honorable Professor Yaşargil, a quien agradecemos por la organización de este magno evento. Asimismo, agradecemos a la doctora Deyanira Katy Casillas, chairman del capítulo estudiantil ASPN, al doctor Salim Abdulrauf, chairman de Walter Irandi Neurosurgery Society, al doctor Baba Kateb, chairman de la Society for Brain Mapping Foundation, todos ellos vice-chairman del comité organizador, al doctor Parmenides Guadarrama Ortiz, chairman del Centro Especializado de Neurocirugía y Neurociencias México. Es un honor presentar la siguiente ponencia a cargo del doctor Kenan Arnautovic. Él es neurocirujano de tumores de base de cráneo, neurocirugía general y columna vertebral en la clínica Senis Murphy en Memphis, Tennessee, Estados Unidos. Profesor del Departamento de Neurocirugía y Neurología de la Universidad de Tennessee Health Sciences Center, Estados Unidos. Presidente del Hospital Bautista de Neurociencias y presidente del capítulo norteamericano de neurocirugía. El día de hoy nos hará el placer de hablar sobre abordaje pretemporal craneoorbitario para la resección microquirúrgica de lesiones yuxtacelares.
Now for our audience in English, hello everyone. I hope you all have a good afternoon. Continuing with today's program, on behalf of the UNESCO Ambassador Jorge Herrera Ramos, Chairman of the World Congress of Neurosurgery, UNESCO ASPNet, Walter Irandi, in honor of Professor Gazi, whom we thank for organizing this great event, as well as Dr. Corrillo and Dr. Urban from the American Academy of Neurological Surgeons Medical Student Chapter at Anak University, as well as Dr. Salim Abderouf, Chairman of the Walter E. Dandy Neurosurgical Society, Dr. Cattell, Chairman of the Society for Brain Mapping and Therapeutics in the Brain Mapping Foundation, all of them vice-chairmen of the organizing committee, and Dr. Parmenides Guadarrama Ortiz, Chairman of the Specialized Center for Neurosurgery and Neurosciences, Mexico. It is an honor for us to introduce you with the following presentation entitled Cranio-Orbital Pretemporal Approach for Microsurgical Resection of Juxtacellular Lesions by Dr. Kenan Arnautovic. He belongs to the school, he's a school-based tumor neurosurgeon and complex spine and general neurosurgery at Sims Murphy Clinic, Memphis, Tennessee, United States of America, and professor in the Department of Neurosurgery. He's also chairman in the Baptist Hospital Neuroscience Line, Memphis, Tennessee, and chairman of International Programs Committee of the American Academy of Neurological Surgeons.
Can you see my screen?
Yes, perfect.
Yes, we do.
Yes.
All right. Well, thank you very much. I'm honored to be here with you tonight or today afternoon. I thank Dr. Herrera for this kind invitation to deliver this lecture on behalf of in the honor of Professor Yaşargil, who is one of my teachers. And I'm going to talk today about cranioorbital pretemporal approach for microsurgical resection of juxtacellular lesions. This is one of the topics that is near and dear to my heart, and I would like to share with all the residents and fellows in the audience some of my experiences in this, as well as with my colleague neurosurgeons. I have no commercial disclosures for this presentation, and just as a way of introduction, I'm coming from Memphis, from the state of Tennessee, which is in the southern part of United States. They call it Mid-South, and it is just by the mighty Mississippi River. And it is a city that is famous for its turbulent past and great present times. They call it also City of Three Kings, which is Martin Luther King, Elvis the King, and B.B. King, and a really hotbed of music and entertainment. And it's a great city to live in and create a great neurosurgical practice. So I'm going to talk today about resection of juxtacellular lesions. And once I reach the end of presentation, end of a lot of time, please feel free to stop me. And also, if you have any questions or if anybody has any questions, please feel free to interrupt me. So just to introduce my School of Medicine and my university. Our university is a 226 years old university of the state of Tennessee, and our medical school is 170 years old. And I've been in this department for the past 19 years. So how do you achieve mastery in microsurgery, and how do you achieve knowledge about the anatomy? One of the most important things is to do the training in laboratory and do cadaver dissections, and do it not only while you're in training, but also when you start your practice, when you, on Saturdays and Sundays, when you attend courses which you teach. And by teaching, you learn more than by presenting. So lab training is one of the first pillars. The second pillar is to have a great teachers of microsurgery. And I was really honored and blessed to have the best of the best. And I appreciate Professor Yaşargil, of course, being in our department in Little Rock, where I trained for so many years, Professor Almefti, who founded the department. And then, of course, late Professor Oliveira, who was dear and near to our hearts, and we still mourn his passing about a week ago. Dr. Krisht and Dr. Boop as well. All of this philosophy about skull-base microsurgery can be sublimated in two main parts. One is Operative Atlas of Meningiomas, which everything you want to know about skull-base surgery, or almost anything, is in there. And also book Microneurosurgery in 4 volumes by Professor Yaşargil. And I always remember this 23 commandments by Dr. Almefti, where he talks about how to leave the bone and remove the bone and leave the brain alone. Think about closure at the beginning of surgery. Never pull or force anything. Don't pull structures, dissect them. And the anatomy of the skull base is complex. It has to be learned, as I said, in the lab. And then you have to have a tip and equipment. You have to have people who are working with you. You have to have your scrub nurses. You have to have your microscope. We also have intraoperative microscope in one of our hospitals, La Bonheur Hospital, where we sometimes do our complex cranial cases. Of course, stealth neuronavigation and intraoperative neurophysiologic monitoring. Here you can see my dear neurophysiologic monitoring person who always is there when I need him and who helps me. One of the essential people are our scrub techs, who are really experienced in microneurosurgery, and also our residents and fellows that live and work with us every day. One of the important things is to have appropriate equipment. Of course, Yaşargil forceps with progressive work length. This is something you cannot operate without appropriate instruments. And I still see some people operating with 1 or 2 sizes bipolars. We need to have different length and different sizes and different tips of micro scissors. We have to use controlled suction, and then, of course, pot scissors, pledgets, and all other equipment. So just to mention a few steps of cranioorbital pretemporal approach. So it's cranioorbital craniotomy, removal of the roof and lateral wall of the orbit, opening of the superior orbital fissure, extradural removal of the anterior clinoid, opening of the lateral wall of the cavernous sinus, opening of arachnoid cisterns with cerebrospinal fluid release, opening of the falciform ligament and mobilizing the optic nerve, and longitudinal incision of the tentorium along the third nerve. So here is the just position of the craniotomy. You see the incision behind the hairline. You see trying to avoid at least the posterior branch of superficial temporal artery, and then burr holes, downward dislocation of the temporalis muscle, dissecting of the periorbita, and performing the bone flap. The removal of roof and lateral wall of the orbit are also important. You can see here opening of the lateral wall of the cavernous sinus, creating a pretemporal highway where you can get all the way down to the cellar, paracellar area. And we use 2-seal and gel foam powder, as you can see here, for hemostasis. And then one of the keys is removal of the anterior clinoid. There is no paracellar cellar surgery without removal of the anterior clinoid, in my opinion. And that really opens up access to the carotid artery and optic nerve, as well as whole cavernous sinus, especially superior orbital fissure. And then knowledge about arachnoid cisterns. You can see here the picture from Professor Yaşargil's book, where we are taught where is lamina terminalis cistern and chiasmatic cistern, interpeduncular cistern, and all the cisterns that we need to open to release the spinal fluid and get to the pathology. So finally, opening of the falciform ligament is extremely important, because that way you can mobilize the optic nerve and then access the cellar paracellar compartment, and then finally open the tentorium along the third nerve. Also, in certain cases, gives you opportunity to mobilize the third nerve and get deeper in the interpeduncular system. So I'll show you a variety of lesions that we remove, and some technical and strategical tips and techniques and maneuvers that we use. So let's start with orbital tumors. This is a 58-year-old gentleman with history of breast cancer and prostate cancer with the right-sided visual loss. These are his images. In this case, we published in Journal of Skull-Base Case Reports. And here you can see the tumor surrounding the clinoid, involving the clinoid. And it was not clear to us before surgery whether this was meningioma or something else. And eventually we found out it was a metastasis of the breast cancer, which is very rare in men. And this is the first reported case of metastasis, sole metastasis to the anterior clinoid. So here we go into the case. This is now opening of the, after opening of the bone, doing craniotomy. And here you can see now exposure of the frontal and temporal lobes. Here is one of the tricks that we use, putting the suture into the ventral, frontal and temporal dura, and retracting the dura, protecting the brain, and enabling us to perform the anterior clinoidectomy. So here you see cutting and coagulating meningorbital artery. By doing this maneuver and dividing meningorbital artery, you can dissect an open superior orbital fissure, as you will see in a minute. And you can see here slowly peeling of the external layer, dura propria of the cavernous sinus on the right side, obviously. And now you can visualize the third, fourth, and V1 nerves. Very important thing, and I'll show this in a minute, is hemostasis at this point. And we do it, as I said at the beginning, with gel foam powder. Gel foam powder is placed in, put in rounded balls, which we compress with small patty, and provides a phenomenal hemostasis in the cavernous sinus area. So here you can see now already exposure of the periorbita. You can see lateral wall and superior wall of the periorbita, and you can see here removing the proximal part as we come to the anterior clinoid. You can see here some bleeding from the anterior clinoid and slowly making anterior clinoid pretty much at the surface of our dissection. Note that there is really no retraction here except for moving of our dissection, moving of our suction and dissecting tool. Further opening of the lateral wall of the cavernous sinus. Here, I noticed that this stump is in my way, meningorbital artery stump, which we retract anteriorly and superiorly to enable us to get into the clinoid area. And then finally, completing the resection of the anterior clinoid. You can see here the optic nerve is being visualized, and with 0.5 millimeter fine Kerrison, Lexel microrongeur, and the drill, we are able here to completely unroof the optic nerve, as you can see here, removing the last part of the bone and using the drill as well, which is using constant irrigation to avoid any heat injury to the optic nerve. Finally, here you can see the optic nerve completely mobilized here. You see completely freed up, and then finally coming to our tumor here, and here is removal of the tumor that is located just ventral to the anterior clinoid. Final picture. Here is the resection of the stump. And here connecting the opening to the third nerve. You can see here ventral aspect of our incision, of our dissection, and you can see here that we are pretty much not even touching the brain. Here are post-operative pictures showing complete tumor resection. You can see here the decompression of the optic nerve and no clinoid. Another case that we operated on is this giant tumor of the orbit, periorbita orbit, and it was completely displacing the left-sided eyeball. You can see here dorsal compression or proptosis, and you can see here post-operative complete gross total resection. This tumor turned out to be plasmacytoma. This gentleman didn't have any primary or other medical problems, and his presentation was diplopia and eye swelling. Another case, lady with previous history of renal cell carcinoma. She presented with declining vision. You can see here her visual fields almost showing almost blindness in the eye, and you can see here in the right-sided posterior orbita a lot of enhancement, about 2 by 2 centimeters. She had the primary history of renal cell cancer, so we did presume that she has metastasis. This case was published in Operative Neurosurgery. You can see here histological picture of renal cell cancer completely invading into the bone of anterior clinoid and orbital wall. You can see here just intraoperative picture of dissection of the temporalis muscle and craniotomy. So here is the case. We'll skip the explanation steps and go straight to the dissection. Here you can see again frontal temporal lobes and then opening of the roof and lateral wall of orbit. Identifying the periorbita and a resection of the involved bone, infested bone by the tumor. Here is cutting of meningorbital artery to open the superior orbital fissure. Again, hemostasis with gel foam powder. To me, much better than 2-seal, although I do use 2-seal sometimes. Here is the opening of the lateral wall of orbit. You can see that renal cell cancers have significant bleeding propensity, and we can tell that this tumor is extremely vascular. So I was first determined to remove all the bone and then remove the tumor. You can see here we are unroofing the optic canal. You can see the optic nerve here. Complete again decompression of the optic nerve. And then here you can see now removing of the remaining part of the anterior clinoid. Here is the optic nerve. Here is the remaining part of clinoid that is involved by the tumor. Here again, drilling with high-speed drill with irrigation. It's very important to irrigate constantly when you are drilling around the optic nerve, because that prevents the heat transmission to the optic nerve. And then here is the part where we are now resecting the orbital part of the tumor. This is periorbita, and here is resection of the tumor, peeling it off periorbita and completely removing it. Finally, there was part of the tumor that was involving the dura and going intradurally. So here we removed it, and then we did the patch graft of the dura with the bovine pericardium. This is preoperative, again, visual fields. This is right eye and left eye, and you can see here almost complete resolution of preoperative visual loss after the surgery and gross total, quote unquote, gross total resection. Of course, there were some cells left, but I think we did pretty good resection. This is a very interesting case. This lady had the left-sided, fairly significant proptosis, eye pain, significant visual field deficit. You can see here in her left eye, there is almost complete loss of left visual field, hemianopsia, and then you can see that this bone is lateral wall and roof of the orbit, as well as parts of the temporal bone are completely involved by the tumor. And this is one of these intraossal meningiomas. Just to illustrate this case is pretty much archaeology, you know. You need to keep digging huge clinoid, protect the optic nerve. And as you can see here, drilling is very long and probably 2-3 times longer than resection of the normal clinoid. You can see here how this left-sided clinoid is gigantic, and you can tell how it's completely involved by the tumor. You can see here we are progressing with a resection. We are using combination of the drilling, combination of the small 0.5 millimeter kerrison, and then dissecting tools, as well as a small micro rongeur. Very long dissection, slow, meticulous, cell by cell, I would say. And then you can see here now the optic nerve is coming into the view. You can see here the optic nerve. Persistent dissection, drilling, dissection, drilling. Here is your optic nerve. You can see it nicely freed here. You can tell that optic nerve in this lady is significantly swollen from this compression. And of course, here is her periorbita and completely resected roof and lateral wall. So there is still some bone here. There is still parts of the clinoid. We are persisting to resect it. And here is the final resection of the clinoid. We are just seeing that we need to a little bit more dissect it and then basically elevate it off the optic nerve. As you can see here now, the optic nerve is completely decompressed. The periorbita is completely decompressed. And what's remaining here is this part of the tumor involving the dura and going intradurally. And we are going to do this as a final part of surgery, removing the tumor. And pretty much completing the resection. You can see here, if you compare, these are preoperative visual fields, and these are postoperative, complete recovery of the vision. So I read somewhere a paper recently that, you know, the recovery of the vision is not to be expected after it has been gone completely or partially. But as I'm showing you case after case, it's really not the case, because with good decompression, protection of the optic nerve, fine dissection, as you can see here on previous and the next cases, the visual field recovery can be achieved. I'm not saying it's always the case, but many, many times it is true. Similar case here you can see on the right side this time, and much smaller tumor, but similar situation where the tumor is involving the roof and lateral wall of the orbit, and you can see post-operative resection of the tumor with removal of the roof and lateral wall and beautiful decompression. You can see optic nerve completely decompressed here and recovery of the proptosis. So moving to another type of lesions, we're going to talk about Clonadal Meningiomas after we showed some of the orbital lesions. So Clonadal Meningiomas come in all shapes and forms and different sizes. And this will be a 61-year-old lady with right-sided proptosis and visual field loss. You can see here on her preoperative imaging that she has fairly significant right-sided involvement or decrease in the visual fields. So again, similar anatomy. I'm going to skip the part that I already went through. Here is opening of the lateral wall of the cavernous sinus again. Retraction with stitches, hemostasis with gel foam powder. Here is opening of the lateral wall. Here is first and second branches of the trigeminal nerve, bleeding from the venous channels, again controlled with gel foam powder. And then here a clinoid becomes surface and needs to be removed, as I mentioned many times. Again, you need to know the anatomy. You need to know where is your optic nerve. You need to know how to core the anterior clinoid from inside, and then basically decompress the optic nerve and remove it completely. So here is optic nerve coming from the view. This is a proximal aspect of the optic nerve. And here is further decompression of the optic canal. Here you can see optic nerve almost completely decompressed, and we are removing final bone of the optical carotid strut. And you can see here, just below my drill is carotid artery, genu of the carotid artery, and now opening of the dura. Now note that dural openings are always preferably low, so we don't see the brain. You can see here, I don't see the brain. This is one of the venous tributaries to the spheno-orbital sinus, which we had to coagulate and divide. And here we are opening the carotid cistern. Here you can see the carotid artery and the optic nerve. and note how there is a branch, one of the perforating branches sitting right from the carotid onto the optic nerve, which we need to preserve. Now connecting the extradural and intradural part by removing the tumor, and then we need to open the falciform ligament. So opening of the falciform ligament is an essential step. You can do it, as I'm showing here, first with hooked knife, like sickle cell knife. We can open it by scissors, or we can use to slide the hook along the optic nerve and open it on the top of the hook with the knife. So either method you use, you need to open completely the falciform ligament. And you see here, coming into the view of the third nerve, here is second nerve, and you have to mobilize the optic nerve in order to access the pathology in the cranial fossa, in the anterior cranial fossa. Now you can see here carotid artery. I'm right here coming to the distal ring. Here there was a little bleeding from the cavernous sinus. I put a piece of gel foam, and then finally resecting the tumor or remnants of the tumor. Here is connecting the intradural and extradural part of surgery by coming to the dural edge. And then here is the final view where you can see, here is the compressed optic nerve. You can see completely decompressed. And you can see here gross total tumor resection. Similar small tumor sitting on the right-sided anterior clinoid. You can see always important thing is to obtain CT scan bone windows prior to surgery, because you want to know when you're dissecting that anterior clinoid how it looks. Is there perhaps a rim of calcified tissue around the carotid artery encircling the carotid artery? And you can see here that this small meningioma is going onto the floor of anterior cranial fossa. You can see here, right, wrapping around the carotid artery. So here is the video clip. Again, we'll skip this part. We went already through this part. Opening of the lateral wall of the cavernous sinus, moving the temporal lobe backwards, opening of the root and roof and lateral wall of the orbit. Here is decompressing the optic nerve. 100% decompression. I call it 360 degrees decompression of the optic nerve. Here is right dissecting it from the carotid artery, which is below. Here is delivery of the clinoid process. And then opening the dura. Again, note, very low dural opening, so we do not see the brain. And then coming on to the tumor. Again, opening of the carotid artery cistern. Here is the tumor coming into the view. Here is carotid artery. And here is arachnoid adhesions to the optic nerve. Here we are dividing them. Note that we are not using any retractors. The only retractors we use is the Yaşargil suction tip, which serves us as an internal retractor. Here is resecting the tumor from the dura. Now we know where is our carotid artery. We know where is our optic nerve. Here is our optic nerve. So we don't have any fear about any anatomical elements that we may encounter. Here is complete resection of the tumor. And then opening of the falciform ligament. Here we are coagulating the falciform ligament. Here we put the small micro hook, and here opening it with 11 blade. And note that once we open the falciform ligament, the optic nerve is free. You can mobilize it gently and basically come into the cellar compartment. And again, you have to do a resection of the dura that is involved by the tumor. So you can see here connecting intra and extradural part of surgery and basically resecting the tumor in entirety. Final pieces of dura resection. And here is your carotid artery, here is your distal ring, here is your tumor completely resected. As you can see here, you can see Picam origin right below. Here, I'll stop this to show this beautiful anatomy. So optic nerve, carotid artery, Picam, third nerve, distal ring, and the tumor, as you can see here, post-operative scans is beautiful. And cosmesis, this beautiful lady, remains very good. Now, these tumors can come in gigantic sizes and they can completely obliterate the carotid artery, as you can see in this particular case. And you can see here by these numerous fingers of the tumor, how they encircle the middle cerebral artery, encircle the optic nerve, and obviously close the carotid artery. So again, dissection starts circumferentially around the tumor. Removal of anterior clinoid is essential, and then slowly dissecting the tumor away from the carotid artery, middle cerebral artery, anterior A1 segment of the anterior cerebral artery, and then achieving gross total resection without any optic eye movement disturbance. Here is a similar case where you can see how middle cerebral artery kind of riding on the top of the tumor. You can see here, and then getting into the middle of the tumor. So for this particular tumors, you have to utilize the splitting technique where you would identify proximal and distal artery. So proximally, you will identify carotid artery, its bifurcation, and then distally, you would identify the middle cerebral artery, and then connect slowly proximal distal part by splitting the tumor into two halves, medial half and lateral half. And you can see here, prior to surgery, we knew that there is some thinning of the A1, there is some dislocation of the middle cerebral artery and elevation. And then after the surgery, surgery went great. We resected tumor, everything but a small piece of tumor that was sitting on the pituitary stalk. And I had dilemma, you see here on the sagittal, should I cut the pituitary stalk or leave it alone? And I decided to leave the small piece of tumor on the stalk because I couldn't develop the good plane and prevent DI in this lady. And I think this was good. We've been following this now for several years, and this is very stable so far. Another tumor, similar, just on the right side this time, you can see here complete blindness. And this is again proof that even patients who have been having complete blindness in the right eye for 2 weeks or so recover it. You can see again the anatomy of the middle cerebral artery, anterior cerebral artery, internal carotid artery, and you can see here tumor completely encircling the bifurcation. Again, we did a resection of this tumor, preserved all the elements. There was just a small part of the tumor, a little 2 to 3 millimeters tumor on the carotid artery, which we didn't dissect and didn't have a good plane. And you can see here proof of what I was mentioning before. You see the right eye here, complete blindness, and you see here regaining 3/4 of the visual field after tumor resection. Another giant right-sided clonadal meningioma with the carotid artery in the center, middle cerebral artery in the center. At the beginning of surgery, you really don't know where to start, where to finish. And these are usually 10-hour surgeries, as you may imagine. And eventually, you deliver the tumor, you preserve the middle cerebral, internal carotid artery, etc. And this tumor had a small piece of tumor on the carotid bifurcation, and we tried to dissect it from below. We tried to dissect it proximally. We tried to dissect it distally, and we decided to keep it in situ, not to violate the bifurcation. And you can see this gentleman here. Now I've been following him, I think, about 8 years. This small piece of tumor, completely devascularized, is stable. Another giant anterior clinoid meningioma, another dislocation of middle cerebral and carotid artery. I'm just going to show here the part of the tumor dissection that here is already exposed tumor. You can see here, tumor very invasive. You see how it's adherent to the frontal lobe. I don't see a good plane. This is telling me that there is fairly significant invasion. This tumor was not malignant, but it invaded the cortex and we didn't have a good plane. So in the interest of time, I want to show you, here you go. So you can see here now, we are starting to show the branches of middle cerebral artery here. This is distally. So distally, I knew here where are my middle cerebral artery branches. And now I'm going to move anteriorly and identify the carotid artery anteriorly in a moment, and then work from proximal to distal, from distal to proximal. All right, so here is carotid artery. Here is the optic nerve. Here is A1 segment. So I know where is my bifurcation. And here I'm going to start slowly working from proximal to distal. And as I showed you before, I did have a distal branches of middle cerebral artery. So in interest of time, we are going to advance. Here is now, you see here how I'm showing the complete length of the middle cerebral artery. And there is one branch of middle cerebral artery riding on the tumor. So I'm not going to sacrifice it until I'm 100% sure that this branch is going straight to the tumor. So again, coagulating feeder arteries to the tumor, debulking the tumor. And then here is the whole length of middle cerebral artery. You can see here the bifurcation. And I'm now sure that this is the branch going into the tumor. So I'm going to look again proximally. I'm going to look distally, and then basically divide this branch and resect the tumor. So you can see here the middle cerebral artery bifurcation. You can see here proximal and distal branch, or superior and inferior branch rather. And then you can see here completely resecting the tumor from the artery and then here is a preserved middle cerebral artery in both branches. This was the branch going into the tumor. Here is the tumor failed, and then here is result with intact. And again, this is left-sided tumor. Similar case, gigantic bad swelling of the brain, midline shift. Actually, I had to do this case on Saturday. I was afraid to wait till Monday. I saw this lady on Friday, and I didn't want to wait. So I posted her next morning for surgery. And you can see here, tumor was involving the bone. So I used bone graft to replace the bone that was involved with the tumor. So basically cranioplasty graft, which is pre-custom made, and you can have whole hemisphere, whole skull, part of the skull, hemicranium, left and right, and then you can trim it down to fit allotted space. So you don't need to resect the tumor and then wait and order custom-made implant. You can there are custom-made, some companies prepare custom-made implants that you can trim down from heavy cranium to size that you need to. Another case, this is intermediate sphenoid ridge meningioma. And then this is, again, encircling carotid artery. You can see here post-operative outcome. Now, how old is too old? Well, I don't think there is absolute contraindication for surgery as long as patient can tolerate surgery. You can see here again, gigantic left side anterior clinoid meningioma in 80-year-old lady who presented with seizure and visual loss. And you can see here dissection with resection of the tumor with preservation of all branches of the internal carotid artery, middle cerebral artery, and lady did well. Cavernous sinus meningiomas. The meningiomas of the wall of the cavernous sinus are going into the cavernous sinus. Here is a sample. If I'm of the time, let me know. I think we started about 15 minutes late. So we have another about 15 minutes and I have about 3-4 more cases. So anyway, here is the same resection technique that we spoke about. I'll move just to the tumor resection part. Here is anterior meningeal artery that has been coagulated, and here we are coming into the tumor by opening the lateral wall of the cavernous sinus. We are right on the meningioma, and here we are intradural. Note here that we are just holding the brain. There is really no real retraction, and then debulking the tumor, and then connecting the inside and outside. So here is V2 outside, extradural, and inside connection. You can see here the dural fold that basically will be removed here, and proving that this is now gross total resection. So you see, tumor is gone. Gross total resection, no eye problems. This is a 71-year-old gentleman who presented first in 2010 that I followed for about 4 years, intractable facial pain, and is actually one of the physicians in town. And this is inside the cavernous sinus, calcified tumor. So we went ahead, opened the cavernous sinus and removed the tumor. You can see here post-operative picture and outcome. This is another 89-year-old gentleman with 6th nerve palsy and severe left-sided facial pain. We watched him for about 8 months, but the tumor doubled inside. Look here in March of 2013, and then look at here in December how much it grew, and we resected it here. You can see post-operative cleaning of the tumor. This was a typical meningioma, which we irradiated. Another calcified tumor on the left side this time, and you can see here a lot of enormous swelling of the temporal lobe. Cellar and supracellular meningiomas. I'll show this left-sided cellar meningioma, which we published in skull-based journal. Here is dura is open now. We'll release the CSF here. You see here no retractor protecting the left frontal and temporal lobes, opening of the arachnoid membrane. Here you can see tumor. This is optic nerve on the right side, optic nerve on the left side. You can see here, I'm opening and showing the anterior communicating artery staying on the top of tumor, coagulating it and shrinking it anteriorly. So really, you don't have any fear here. You have whole anatomy in front of your eyes. You have right and left A1. You have both optic nerves. You have carotid artery. They're all exposed. They're all superficial now after a COZ approach. So you are not working, you're working with short instruments. There is no pulling, full control. There is no loss of smell. There is no CSF leak. Chance is 0, not 10%, not 15%, not 3%, it's 0. And here you can see basically resecting this clonadal, tuberculum cellar meningioma. And I'll show you beauty in a moment. And here is the chiasm, obviously, optic nerve. And then here is your pituitary stalk and pituitary gland. Beautiful anatomy. So again, chances of, here is postoperative outcome. Chances preserve pituitary stalk, preserve pituitary gland. Chances of CSF leak, 0. Chances of loss of smell, 0. Another tuberculum cellar meningioma, blindness before surgery, recovery after surgery. I will just show the very end of the case. Here is removal of the tumor. You see here the optic nerve, how mobile it is, and how we were able to reach below the optic nerve. Here is the attachment of the tumor at the tuberculum cellar area. Here is working above the optic nerve, resecting it between the two optic nerves. And here is the pituitary gland, pituitary stalk, right optic nerve, left optic nerve, gross total resection, brain untouched. And you can see here, patient improved slightly his vision after surgery and gross total resection. Here's another case, tumor, tuberculum cellar meningioma. Here, please pay attention. Here are bilateral, almost blindness bilaterally, and look postoperatively, clearance of improvement of vision and gross total resection. Another case, we have case after case after case. Bilateral blindness for 2 weeks, tuberculum cellar meningioma. In the interest of time, I'm not going to show the the video. And here, gross total resection. I think left side almost 100% improvement of vision. Right side, I think probably 80% improvement. You can compare preoperative visual fields and postoperative visual fields. 2 weeks blindness. This lady was operated somewhere in another center, very well known actually center, very well known skull-based neurosurgeon. But the problem is it was operated in 2016 and then presented to me with further worsening of vision. And you see here, there is involvement of the optic nerve on the right side. There is the residual tumor is sitting on the tuberculum cellar planum sphenoidal area. And this surgeon did excellent job. I mean, you see the tumor in the cella is removed. So I can't understand why this easy part was not removed. And the lady was coming with worsening vision because she already postoperatively had her left eye loss, but the right-sided vision was in jeopardy. So we had to do surgery to try to save the remaining minimal vision that she had on the right side. So here is postoperative pictures You see here that small remnant of the tumor compressing the optic nerve was resected, and that small vision remnant was preserved. This lady I did just 3 days ago. She just went home, third postoperative day. You can see her postoperative visual field on the right side, left side. We didn't, this hair postoperatively, we didn't have a chance to obtain postoperative visual fields. We'll get it when she comes back. But you see here preservation of the pituitary stalk and pituitary gland. So I'm coming close to the end. I'll just show quickly one craniopharyngioma. Here is opening of the lamina terminalis. Here is removal of the tumor. You can see here optic nerve. I'm working below the optic nerve. You see by opening of the falciform ligament how much space we have between the carotid artery and optic nerve. And here I'm working between two optic nerves. And then finally, here is the final view with gross total resection of the tumor and preservation of the pituitary gland. Another craniopharyngioma going behind the clinoid, behind the pituitary gland, before surgery, gross total resection. Another one. And then I'll just show you one pituitary adenoma sample. This is pituitary adenoma going and wrapping around the pituitary gland, pituitary stalk, and then going into the anterior cranial fossa and going, spilling over behind the clinoid, behind the posterior clinoid into the posterior cranial fossa behind the pituitary gland and clivus. So we resected this tumor. You can see her preoperative blindness bilaterally, and you can see postoperatively on the left side, we regained about 50% of vision. On the right side, roughly the same. And you can see here, the only part of the tumor that we had to leave is this little tumor around the pituitary stalk, because again, I was facing the dilemma, cut the pituitary stalk or and have DI or leave a small piece of tumor, and I decided to leave it. Zero CSF leak chance, zero chance of loss of smell. Aneurysms also can be dealt with. In the interest of time, we'll just show ophthalmic aneurysm here, and then basilar tip aneurysm, triple aneurysm, basilar tip, middle cerebral artery bifurcation, and PCOM. And then finally, glioblastoma, which we also use pretemporal approach to go ventrally and come from the inferior surface of the anterior frontal lobe. You see here it's coming to the surface of the frontal lobe. So we could split the fissure and go from transfissure. We could go through the cortex, and we decided to go below from the inferior surface of the temporal lobe. And you can see here, nice resection. Trigeminal schwannoma, also very nice tumor, probably the easiest of the tumors because it's completely extradural surgery. You open the lateral wall of the cavernous sinus and you are on the tumor, and then tumor creates you a highway into the posterior cranial fossa along the fifth nerve. And you can see here resection. Another trigeminal schwannoma. So, in conclusion, I'll say that this is a great approach. This is a workhorse of all anterior cranial fossa, middle cranial fossa, juxtacellar pathology. It enables radical surgical resection. first time is the best and only time to achieve cure. So always resect 100% or close to 100% tumor. This, again, approach help preserve anatomic structures without any loss of smell. There is no risk of CSF leak. Helps preserve pituitary gland, pituitary stalk, and pituitary hormonal physiology, and preserves cosmesis. So thank you very much. I'll be happy to entertain any questions if anybody in the audience has some.
Thank you, Doctor, for your time and for your incredible presentation. Sorry.
We really appreciate your time. I was wondering if you can bring us your contact, please.
I'm sorry, I didn't